Okay, so I'm just going to do a quick intro for our panelists. So, starting right here. You want to introduce yourself, but...
I'll introduce myself. Since I've been left out of the program. My name is, as I mentioned earlier, Ted Zeltner. I trained here at Albany. Started my medical school in 1971. I hate to tell you this, my tuition was $2,200. When I finished in 1975, it had doubled to $4,400. So I want some sympathy. I did a state medical internship here, did my internal medicine residency here, and as maybe we'll get into later, I don't want to take up the introduction time, but I made the decision to go into primary care internal medicine for a number of reasons, which I will be happy to share after the introductions.
I'm Dr. Annie Rutter. I'm a family physician. I was a medical student here, not when tuition was $2,200. A little closer to what you guys are paying. And yes, you can pay off your loans, and you can go into primary care out of Albany meds, and don't let it deter you. I graduated here, did my residency at the University of North Carolina at Chapel Hill. Came back here to be faculty after that, and have been here since 2011. Recently taking over with help of some colleagues, the clerkship in family medicine, and so I'll see all of y'all a lot. We see each other in the third year, so most of what I interact with students is in the third and fourth year, but excited to be here, so thanks for having me.
I'm Lynn, Keil. I'm a physician assistant. I've been a PA for over 20 years. Worked actually up in the Adirondack Park for Dr. Runge and Hudson Headwaters for over 20 years. Throughout that time, also, I've been a clinical assistant professor at SUNY Stony Brook, where I graduated from. After I graduated in 1993, I won a National Rural Health Association fellowship, and I was placed in the Hudson Valley in New Paltz, working with migrant farm workers. I was there for 6 months, going out to the farms and doing a lot of interactive care, as well as care right at the clinic. I was the sole provider, and would have a lot of late-night telephone calls with a family physician in the emergency room in Kingston Hospital. But I really like family practice. I actually love family practice. I like all the parts. You have to say to yourself, you know, you never know what you're going to walk into.
My name is Richard Haldeman. I'm a PA myself. I've been a PA now for 13 years. I started out actually as a paramedic planning on going to medical school. Went to the School of Public Health at SUNY and became a policy wonk, and decided I still wanted to do clinical medicine, but I really felt like to do policy as well, I'd like to become a PA, which I did. Hudson Valley PA program, graduated that early 2000s. For the next 10 years, I actually spent my clinical time downstairs in the ER at Albany Med here, understanding that there's a lot of primary care done in the emergency department over and over and over. So I was lucky enough to have an opportunity to go to Whitney Young Health Services. Anyone knows about us. We're down in Arbor Hill. We're a federally qualified health center, level 3 patient center medical home. So our primary care to us is it's more than just medicine. It's the social aspects. It's the entire patient.
So my name is Sheridan. I'm a pediatrician at Schoolhouse Road Pediatrics, right near Stuyvesant Plaza. Most of you probably know where that is. Well, Crossgates if you don't know where Stuyvesant is. We also have an office in Greene County, about 30 minutes south of here, in Coxsackie. You'll all learn about the Coxsackie virus at some point. I went to medical school at the Royal College of Surgeons in Ireland. I graduated in 2003. When I was over there in 2001, my rotation in primary care was sitting in the GP's office in his home for 4 weeks as people came into his house to be seen. When I did my pediatric rotations, there was no pediatrician, general pediatrician. If you were a pediatrician in Ireland at that time, you worked in the hospital. You had to. You were a hospitalist essentially. So I was very excited to come back to the States for that reason and practice primary care pediatrics because that's what I wanted to do. So I've been here. I grew up here, so I've been here practicing for 8 years. About 8 months ago, I decided to jump into the insurance world and see what that was like. We know the Affordable Care Act is changing things on a regular basis, and primary care is changing with that. And seeing the way primary care is treated by the insurance companies is interesting, but I think it's moving in the right direction, so I could talk a little bit about that. Because part of paying down your student loan is making sure you're getting paid, and who pays us.
So I guess the first question we'll have the panelists kind of talk to is, why did you go into primary care? So starting here, you joined it on the line.
Well, I think when I trained, there were a couple of arguments people made, both pro and con. One of the things that people were, I think, basically afraid of primary care. And one of the arguments was, it's too broad. There's too much to know. I can study the eyeball and learn everything there is to know about that, or I can look at the heart and look at and master that. But I can't master everything. I can't know about the eye and the heart and the kidneys. It's just too much. I'd rather specialize. And I think what you learn as you go through your training is that when you train, you know, when you're finished, you will know how to treat 95% of the people for 95% of what they have. And the 5% that you're not sure about, you'll know where to go to find out or who to refer them to. So as it turns out, you can do a lot of good in primary care, and it's not too broad a field to look at. And that links up to the second point I'd like to make, which is when I finished, I was fortunate. I was offered 3 fellowships, and I elected to turn them down. And the reason was that I had an interest in a lot of different things. And primary care allows you to do that. When you're looking at cardiology, the idea of doing a coronary angiogram or doing an echo sounds like very exciting. But if you sit back and think after your first 100 catheterizations, how interesting is it going to be to do your 101st? And if you're looking at a GI fellowship and doing endoscopies and colonoscopies seem like fun, well, I'm sure they are for the first 25 or 30 of them. But after that, it's routine. It's like putting your socks on in the morning. And what I realized for myself was I like some of rheumatology, and I like some of pulmonary, and I like some of infectious disease. And the way I could do all of that was to go into primary care. And the third thing I'll just summarize to say is it's the one field where you really get to know your patients. And you look at the whole patient, and you take a lot of things into consideration. I can tell you that when you go to orthopedics, they're only interested in your shoulder. And you could say, but doctor, go see your primary care doctor. When you see a cardiologist, they're interested in your heart. There's nobody except the primary care doctor that's really interested in the entire patient. And that makes it tremendously interesting. Because specialties, they're great and we need them. But for me, I like the variety, and I felt the training was terrific for that.
So for me, I wasn't going to go into primary care. I went to Union, so if anybody's a Union kid, so I'm a program kid. And so I went in, and I was totally going to be an orthopedic surgeon. I had played sports all my life. The only doctor that I had seen ever besides my pediatrician was an orthopedist, and he was super cool, and he did x-rays in his office, and he showed them to me, and that was awesome. And so at 18, that sounded like a really cool idea. And then I went to Union, and I got my undergrad degree, and got my master's in health systems, and I said, holy crap, primary care is the only way to actually provide care for patients in this broken system. And exactly what Dora was talking about, we see this data, and I was like, this is a mess. You know, it's so good in Ireland or in England and these places that have this broad primary care base. And I said, well, I can talk the talk, but now I got to walk the walk. So came into medical school, interested in primary care, wasn't quite sure what avenue to take. Came from Long Island, had never even heard of family medicine. Never even heard of it. It wasn't a thing. It was pediatrician, and then if you needed somebody, it was the specialist, but had never heard of family med. So came up here, met some family docs early on in my first and second year of med school, and actually had a terrible family med rotation. It was terrible. It was boring. The guy I worked with only saw adults, and I was like, well, this is a lie. Family medicine is a lie. All I see is adults. This is super boring. And then I went to panels like this and learned from people, no, that guy's just boring. And primary care crew will be excellent. And it's been awesome. You know, know, I chose it because of the same things Dr. Zeltner talked about. It's the ability to have continuity with your patients. Yeah, if you're a hematologist oncologist, you have continuity with your patient. You see them every week for their chemotherapy, and then hopefully then you cure them and you send them back to their primary. And there are words, you know, that we hear from, were mentioned the hidden curriculums, or these underpinnings of you're too smart for primary care, or that's a waste of your education. You went to Albany Med, you can't afford to be a primary care doctor. All of those things, and very quickly what we learn is the best compliment someone can give us is the orthopedist who says, I'm just looking at your shoulder, please take that back to your primary. And as a primary care doctor, you say, yes, thank you. Please don't try to fix anything else. And so there's a lot of pride in being able to do that. And again, you have your specialist for help. So for me, it was a little bit of a journey, but once I was committed, then primary care was the only thing that made sense for me and my interests.
For me, it was, when I got out of school, there weren't a hell of a lot of jobs as physician assistants. And I was very fortunate and very lucky, as I said, to get that fellowship and to place me in the Hudson Valley. And yes, I was dealing with mostly, you know, adult and migrant male workers, but there were kids. And it was just such a wide open field. And then I would go over to the OB clinic and I would spend a little bit of time over there. And then when I came up to Hudson Headwaters, I did mostly urgent care, and you never knew what was behind the next door. So it was always challenging my skills. And there's not a better compliment, I think, that when like I'm at the hospital and you get asked to do a consult for the orthopedics mostly, to go through their med list and make sure that the patient is on the right diabetic medications, or the extension of, not only do I know you, I know 6 of your other family members, and you know, I call it collect all 6 because now all of a sudden, you know, that one family member is bringing everybody to see you. It's really, no, you know, as fun as it sounds, it's a really rewarding feeling saying that they trust you to take care of their family. It's a really big job.
For me, it was when I had finished the PA program, the same issue. There were a lot of jobs, and one of my first rotations was family practice, and I had a nurse practitioner that was just free. We just hit it off. When I did finally finish the program, the only thing that was available at the time was ER jobs. There was a lot of ER jobs for PAs. So came back to the medical center and spent my time here. And as I did more primary care in the emergency department, I really developed a breadth of knowledge. Of course, the PA program, you know, I had the basics of, but after a few years in the department, I realized that doing a lot of primary care, but I wasn't really stemming the tide. I was seeing these patients for episodic primary care, trying to get them into other people. And again, as Dr. Rutter said, you eventually say, you know, I talk a lot about health systems fixes, and you eventually have to start walking the walk instead of just talking the talk. So having the opportunity to go to a federally qualified center, to a patient center medical home has been great. It's there's issues everywhere, underfunding, large patient populations, really sick patients, but you make a difference. You do. These people look to you to sort of keep them together.
There's a patient that CDPHP talks about who I believe in 2012 went to the ER 712 times in 1 year. Yeah, oh, well, sure, you know. And it was once or twice a day, and they would literally seek anything from the hospital. So that one of the goals from case management from CDPHP when that was discovered was we need to get that person a primary care provider. That's crazy. But for me, I remember who here was a camp counselor? Anybody? So okay, yeah, usually that's the case. So one of the things that I hated doing as a camp counselor was talking to the parents. They were always complaining about something. Nothing was ever right. We were on a field trip where we would leave camp every day. There would be 12 kids and 2 counselors in the van, and our van just stunk. These were like 6th and 7th graders. So we knew one kid just wasn't wearing deodorant, or maybe more. My brother was the other counselor with me, and he said, I know who it is. It's Billy. Billy stinks. He's not wearing deodorant. I know he's not. And so he's like, go walk by him. Sure enough, you walk by Billy. My brother's right, Billy. Well, I was the senior counselor at that time, so I have to talk to this mother. And this was probably the worst mother for me to have to talk to. So I just said, no big deal. I'll just have my boss, the head of the camp, call Billy's mom and say, Billy stinks. You guys and she turned to me and said, I'm not doing this. You need to do this. This is something that you have to do. You're going to be better in life if you do it. And she made it. So I had to think, how am I going to get this point across to Billy's mom? I did talk to the mom. It was not easy. It was very hard. But I found by the end of the conversation, Mom was very pleasant. I had found a way to tell her something terrible about her son that was probably pretty embarrassing for her, especially when I had to tell her I think the other kids were starting to pick up on it as well, which we learned throughout the day. The next day, she calls me up in defense of her son. Listen, I talked to Billy. I spoke to him. I sniffed him up and down. Is what she said to me. It wasn't Billy. He wasn't the stinky kid. I said, no problem. But she said, but you know what? He hasn't been wearing deodorant. It's time we had that talk with him and have him start wearing deodorant. The problem went away. And I found that there were multiple stories like that that made me say, I'm actually pretty good at it. As much as I hated doing that, I'm sure we all know now, talking to parents, giving them bad news, giving anybody bad news isn't easy. I think everybody up here gets very good at it, and I found I was pretty good at it too. So one of the reasons why I thought that this is a perfect job.
Okay, so our next question, this one's directed to the doctors. We will have questions for PAs as well. So this question, I know you guys have heard a lot of concerns that we have from the audience here about your experience in primary care, so I think it'd be great if you guys could address some of these concerns, like the long hours, the increased demand to see more patients with less time, the paperwork and the bureaucracy, the lack of support. We will have a question later specifically about the financial burden, so you can touch on it now, but you'll have time to expand on that later as well.
Well, I mean, there are certain realities of practice that you can't deny. There's no question that the hours are long, although as many of you know, there's been a shift from what used to be the old solo private practice to more or less clinic work, where hours are much more defined. So there are ways, depending on what your personal preference is, where you can do your own thing and work as long as you like, or you can opt for a primary care position that's more defined from an hour standpoint. There's also no question that the paperwork burden, prior authorizations for blood work, for x-rays, for drugs, has put a large burden on the primary care physician. And specialists are good at shunting that off to primary care and saying, well, you need to get this. For instance, I just had an example. One of my patients saw a pulmonologist, and she had chronic lung disease, and she saw him, and he prescribed her a nebulizer with medication in it, and gave her a prescription for the medication, but said, go get the nebulizer for your primary care doctor. Now, you know, that's horribly aggravating in some ways, but in some ways you just do it because you have no choice. The patient needs it, and the patient becomes the football if you don't do this. So yes, there has been a burden of paperwork and hours, but you know, the rewards of doing what we do outweigh that. And some of the ideas and advocacy that may come from groups like yours is how do we streamline this paperwork, and how do we get around some of these things? How do we change some of these rules and regulations if possible? But it's worth it. You have to do certain things, but it's worth it.
I think the most important thing is that there's a lot of practice models out there, and Dr. Zeltner, sort of looked at this a little bit, but there's something you guys should look into if you're very worried about this aspect of care, and it's called direct primary care. And direct primary care is a practice model where essentially, physicians are paid by the patients themselves directly, and then provide care and in a direct way, and meaning that the provider is available to that patient all the time, and that the provider is available to them because they pay right into the provider's pocket, and that way there's no paperwork. There is no in the middle that happens with regards to that. So, yeah.
Did you see like a different proportion of patients do that with content?
Yeah, so the people that are, I'm not in a direct primary care practice, but the people who do that tend to see a lot less patients, and they spend a lot more time with their patients.
Would it be like higher socioeconomic?
It doesn't necessarily need to be. I always thought it was, but that's not necessarily the case. But then the individual provider can go and work with people like Brian about, how do you get CDPHP then to work with the patient or with me. So that's one practice model, but others are clinic practices. There are ways to do inpatient hospital practices as part of what you do. So I think the important thing is to find a practice model, the business part of medicine that you guys don't get a lot of learning about in medical school. To do that investigating and learn what's going to work for you. There are opportunities to have people assist you with some of this paperwork, So a lot of it I do myself because I use my nurses for other things, but there are other people who you can kind of coordinate with and say, all right, if you can work on this for me, I'll do this for you. And the example you gave about the nebulizer, stuff like that happens all the time. But now you know that patient's on a nebulizer instead of having no idea what the pulmonologist did for that patient. Because without a centralized electronic medical record, people go to specialists, they come back to you and they say, I don't know. So what did the pulmonologist do for you? He gave me this medicine. Do you have it? Bring it home with you?
You call it the witch doctor, like which one did you go to?
Right. Even in a system like Albany Med, the communication is not great. So you have to, so that's a way to actually, sometimes insurance companies is the absolute best way to get information about your patients. It's a great, because they're some of the best communicators about how to see what's going on with your patients. So I think it's being open-minded. I think it's looking at different practice models and realizing that not everything is 50 patients in a day, see as many as you can, throw up at the end of the day because all you've done is not even had a chance to go to the bathroom. It doesn't have to be that way.
Is there no stigma within primary care that if you do opt for one of these lesser volume practice models that you won't be seen as really fixing the problem? You're not seeing enough patients, or do people see it as a cop-out?
So part of the model that comes out of is improved quality of care. And so it's actually, while you're potentially seeing less patients, the quality of the care you're able to provide is you're actually farming out patients to specialists less. Because if you have 15 minutes to see a patient, you may say, okay, I have enough time for 2 of your problems, but the third problem I'm going to send you, it's not very complicated, it's just asthma, but I'm going to send you to the pulmonologist because I don't have time. If you have an hour with your patient, you can actually address all those issues and you can keep those 95% of patients that you've learned how to care for right in your own office. And so you're actually cutting costs and cutting it that way. In my understanding, I haven't seen any stigma with regards to models of care. Everybody has their own preference for what they go into, and you may graduate from a residency, and you may not even, after a couple years, if you don't keep in touch with people, you don't even know what they ended up doing, because people's careers, even within family med, you've heard, or primary care in general, you've heard of this whole panel that everybody's career has sort of taken a couple different paths, and it keeps that flexibility.
Even if your career is like a relatively young one, because in some specialties they want you to work like crazy right when you get out of residency, kind of build up your profile or whatever. Is there not that pressure as well?
So I don't know if other people want to answer, but I feel like that's it's a practice-driven thing. That's not a specialty thing. So that's not the Board of Family Medicine saying to you, you need to turn out 150 patients a day. That's, if you're going into a certain type of private practice or a certain type of practice model, they may have those kinds of demands. But in general, the field of family medicine or the field of internal medicine is not telling you, the board isn't telling you you have to see this many patients in a day or something like that. There's not that pressure. There's no numbers you have to hand in at the end of it. You could graduate residency and see patients a day a week if you want to. Keep your license up.
Can I just add one thing, though?
Yeah.
It depends what kind of practice you go into, as Dr. Rutter's saying. If you want to be in a private practice, there are economic realities where you have to make a living, and you have to break even or make a profit. Otherwise, you're out of business, like any business. If you lose money, you're done. So there is a drive, and I want to be honest with everybody, there is a drive that if you're in a private practice or you're in a private group, there is going to be a drive. Nobody sees 10 patients a day in the private practice world and survives. But if you're working with an organization, you're working with somebody and you're on salary, and you're not, eating what you kill, as they then those practice models become much more realistic because the funding to support you as a practitioner comes from a larger group. And if it's that group's philosophy that you practice in a certain way, they will support you to do that. So I agree with Dr. Rutter that that's all possible, and there is no stigma if you choose that kind of an option. But everybody should understand that if they don't choose that kind of an option, and you do go into private practice, or with a group that's in private practice, there are certain economic realities. I mean, you have to generate enough income to be able to pay the lights, the utilities, and the rent. And so, you know, there is some drive to see a certain volume.
I think in some cases your practice will tell you what your panel is going to be if you're looking at coming on board. So,
When it comes to the long hours, my advice is really do what you want based on your economic capabilities at that time. When I finished residency, I was getting married. I had no kids. My wife was a teacher, so I would work as much as I could, and I was moonlighting, and I was doing everything, you know, and I was fine working 50, 60 hours a week, which is a lot for a pediatrician, so don't ever think that and now, when I got into my practice, the first year, one of the coolest things they said to me was, for your first year, as you're building your own patients, you're going to get a flat salary. So you're going to make this whether you see 10 patients a day or 20 patients a day. And I probably saw on average about 18 patients a day my first year. My second year, I got the hang of the routine. My numbers went up, and then I would start to get bonus pay on top of that, depending upon what I brought into the practice. By the time I became a partner, at that point, it's you see it, you treat it, you get paid for it, and that's how it was. So when it comes to the hours, really do what you think is best for your family and your economic, need at that point. We have the power to do that in primary care. I think that's a good thing about primary care. If you're a surgeon working in this hospital, you don't control when you work. They tell you what your schedule is going to be, and that's really it. Unless you're one of the ultra specialists here. But if you're a general surgeon here, they're going to tell you when you're working, and that's probably when you're working. When it comes to the number of patients you see, you can dictate that. Absolutely. There are plenty of pediatricians that I know of that have said, I'm not taking on new patients. I will only replace my patients at this time with new families if they have another child. But right now my practice is closed. I don't think anything less of them because they want to provide excellent care by spending enough time with their patients, and they're happy with how they're doing that. I think if you join a big group, that would be the third point. The financial burden of running a practice is much easier when you're in a group practice. So I don't care. I have 7 partners. I think that's okay. I would be happy with less. I don't know if I'd be happy with much more. But that's my own personal preference. I think it's hard to go it alone. But just going back to the lack of support, I think that's why I would tell you make sure you're in a practice with supports like that. Again, one of the things I do at CDPHP and I've been able to learn was there was a surgeon who wanted to join the CDPHP network who had 10 lawsuits against them, and they were all back in 2001 to 2007. In 2008, these lawsuits went away. So this person wanted to be a part of the CDPHP, and we said, well, how were they sued so many times and then nothing? And the difference was they were a solo practitioner surgeon at that point. They were getting help very sparsely from other people in the community. Once they joined a big practice, they got the support that they needed. So I think that is something that you guys should look at too. Make sure you have enough support wherever you decide to get a job.
All right, so the next question is going to be directed toward the PAs. How will roles for nurse practitioners and PAs change due to the shortage, and what effects do you think this will have on the balance between MDs and other practitioners?
That's a big question. How have the roles changed? From a PA point of view, I actually think in the past probably 15 years the roles have changed the wrong way. A lot of my classmates, a lot went into specialties. 2006 when the resident rule went into effect. I can't remember when it was. The 80-hour resident rule, PAs in surgery became really popular. NPs and PAs became really popular because the residents weren't allowed to work 120 or 140 hours a week. I'm not sure that I see my role changing. Part of my role is administrative, but we're all collaborative in the group that we're in, very collaborative. Dr. Zeltner has come on board recently and has been just a great resource to have for the mid-levels, as well as the rest of the staff. But I think you bring what your experience has. I can handle things a little bit better on an urgent basis in the office, as opposed to some of the other providers. But I don't know how the roles change. The other question that you had after that role?
Just
the balance. It's an interesting question. Everyone's looking at that right now. NPs and PAs, where they fit in, how we're going to manage. The nurse practitioner rule was into effect in January, which is that in New York, nurse practitioners will not need collaborative agreements anymore. Dr. Zeltner and I discussed this sort of, ad hoc, and I don't know how that's going to play out. I don't know how that's going to affect the relationship between physicians and adult providers right now.
Do you ever know what that means? You guys? No?
So nurse practitioners right now have to have a collaborative agreement with a physician. As a provider at this level, we agreed when we graduated that we would always work for physicians. Nurse practitioners are changing. They will be autonomous in New York State anyways, as of January 1st of this coming year. Which means NP can hang out their shingle. So there's definitely some issues with how physicians feel about that. The schooling is clearly not the same. The experience in school is not the same. The medical model and nursing models are different. Both have a lot of strengths. So that's probably, I guess, one of the biggest ways that the roles are going to change. From a PA point of view, there's always an underlying push for autonomy. We see that periodically. I don't necessarily see that happening, though. I see us always working with physicians.
Yeah, and I would agree. Actually, in our practice, we're treated as colleagues. We're not treated as working under the physicians. At the hospital, especially when I'm rounding, we divvy things up in the morning, and I see half the patients, the physician sees half the patients, and then we round it at noontime and then again before we go home at night. The nurse practitioners currently that work for our office are also treated as colleagues. I don't know how the new legislation is going to change things in my office. I know that the nursing lobbyists have always been a hell of a lot stronger than the PA lobbying groups, and have really made a push. This is not just something that has been going to be changing in January. This has been, since I was a student. So this has been 20 years in coming. To own their own practices and sometimes to hire physicians to work with them, which will never happen in our career. I know that this is a very hot topic at our national meetings, even at our New York State meetings, and even at I served on the New York State Medical Board for 10 years, and this is always a topic that comes up, and how things are going to be handled, and almost like a turf war between physicians and the nurse practitioners in some areas.
I've always been a proponent, I'm sure you have too, of collaboration. In Albany in general, Albany Med in general, has always been sort of what I refer to as PA friendly and NP friendly, only because the Hudson Valley program graduated its first class in 1972, so we've been around a long time. So the sort of collaborative relationship, the collegial relationship is much different here in other parts of the country, for sure. So that's a good thing. And when we teach, both of us have taught NP students and PA students, and you try and get rid of those silos. I'm using the word silo, but those differences. What makes us different? Well, what makes us the same? Well, we're
But basically, the nurse practitioners are trained by nurses. We're trained by doctors, and we're trained by the traditional medical model. And so oftentimes, stepping into the clinics, we've already been there, and we know what that's all about. And sometimes I find actually with the new students that are coming out, I think a lot of times the PAs are a little bit better prepared than the nurse practitioners, but that's not 100%.
Okay, thank you.
So I have a little bit of data I can share. I just was at a conference. Andrew Bazemore is a really interesting guy. He's the director of the Graham Center. The Graham Center is a primary care research collaborative, and it's a super. If you guys are interested in primary care, you'll hear more about the Graham Center.